So next we'll have Dr. Srinivasan, who's the Chief Medical Officer of Agarwal Tambaram branch, on talking about how do you manage when you have a double trouble like combining cataract and corneal problems.
Yes, RAO. No, not that. Below one. Yes, RAO. Yeah. That machine made simple.
None of the producers have any financial interest in any of the products or procedures mentioned or shown in this film. No copyright infringement intended for the music used in the video. If you have a blurred image during surgery, what would you do?
Rub my eyes to have a clearer vision.
I will ask my assistant to probably clean the microscope lenses.
Change the microscope bulb.
I would dim the OR lights.
I would probably scrape the cornea.
I would refer to an expert surgeon.
Endo Illuminator, machine made simple. The surgical approach in eyes with poor visualization is highly challenging. When visualization of intraocular structures seems inadequate under the operating microscope, a simple modification in the surgical procedure by having an endo illuminator can be the game changer. Endo illuminator works on the principle of oblique illumination, wherein the eye is directly seen under the microscope with the light of the microscope switched off and the endo illuminator being held at an angle of more than 70 degrees externally along the limbus to illuminate the anterior segment structures. It improves visualization by providing a stable, stationary, and diffused form of illumination. The illumination is based on a wide-angle approach resulting in low irradiance. Intracameral endo-illumination reduces the light scatter and glare, maximizing corneal transparency and allowing safe and effective surgery. Since 1993, use of endo-illuminator has been described for cataract surgery for visualizing the anterior capsular flap in hypermature cataracts. Endo-illumination guided irrigation and aspiration during combined 23-gauge sutureless vitrectomy as well as endo-illuminated infusion cannula for bimanual anterior chamber vitrectomy has also been described. Handheld fibers exhibit smaller illumination angles. However, they are more focused. Current illumination systems consist of high-intensity light sources and single-use endo-illumination fibers up to 30G. Existing devices employ xenon, halogen, mercury vapor lamps, or light-emitting diodes, LEDs, as light sources. Commercial systems available from Synergetics, Alcon Laboratories, or DORC. Use of endo-illuminator is described sparingly in anterior segment surgeries. During anterior segment surgeries complicated by hazy media, endo-illuminator acts as an external light source, enhancing visibility of the operating surgeon, aiding in smooth performance, achieving better surgical outcome. Here, we describe a series of challenging surgical scenarios in which the technique of endo-illuminator assisted surgery was performed with ease. The first case is of scarred cornea, in which visualization of the anterior chamber and beyond was arduous. Even after debriding the epithelium, coaxial light of the microscope doesn't help much in visualization. This is where the endo-illuminator comes to the rescue. It helps to visualize and implant a glued IOL. The next scenario is that of a post-traumatic cataract with iridodialysis. The endo-illuminator helps us in visualization of the remnant iris while we use the piecemeal technique in different areas to refix the iridodialysis. It also aids in better visualization of the vitreous strands when dye is not used. Furthermore, it helps while passing the 9-0 needle through the iris during single-pass fourth-row pupilloplasty and cutting of sutures post-SFT. In the next case scenario of a failed PK graft, the role of endo-illuminator is substantial as the opaque failed graft doesn't allow any coaxial light of the microscope to pass through, and endo-illuminator helps in visualizing structures underneath. The endo-illuminator also aids in the formation of Purkinje images, which guides the centration of the pupil post-pinhole pupilloplasty using the single-pass fourth row technique. In this interesting case of an ACIOL with summering ring in which the haptics were stuck in the anterior chamber angles, endo-illuminator assists in visualization and creating surgical iridectomy to release the haptic, and also while burping out the summering ring out of the AC and vitrectomy. In this case of glued IOL, where the haptic of 3-piece IOL broke, endo-illuminator comes to the rescue and helps in finding the broken end of haptic and safely explanting the haptic and damaged 3-piece IOL out of the eye. The view of the P-deck graft is enhanced when the endo-illuminator light is added to the field. When we put off the microscope light and just use the endo-illuminator light at an oblique angle, it gives beautiful illumination and excellent depth perception. The comprehension by the surgeon of the graft orientation and the graft dynamics within the anterior chamber is much better, and the direction of the graft can be easily made out. The unfolding of the graft can also be carried out with just the end illuminator light alone, and this gives a very good clarity to the surgeon, as you can see here, as opposed to the microscope light, where it is very difficult to make out whether the graft is facing upwards or downwards. You can see here the visualization is improved as compared to a very poor understanding of the graft with the microscope light alone. In case of inadvertent trauma to the Descemet's membrane, it can cause Descemet's membrane detachment, which might be very small and can get unnoticed, causing long-term corneal edema. Endo-illuminator light, when falls at an angle, can help in the visualization of these small breaks in DM. Vitrectomy endo-illumination attachments are often available, which allow aspiration infusion and vitrectomy. Apart from the above scenarios, it can be used in cases of trauma, chronic degenerative changes such as Labrador keratopathy, bullous keratopathy, corneal dystrophies, PPP, glued IOL, surgical iridotomy. Endothelial contact should be carefully avoided throughout and positioned inferotemporally and supported by the assistant. The endo-illumination probe should not physically interfere with microsurgical manipulation within the AC. The endo-illuminator aided modified approach to such cases is highly feasible, practical, and convenient. It can serve as a smart addition to our surgical armamentarium, as patients with concomitant pathology can still get good post-operative vision with this modified technique, helping achieve better results both intra and post-operatively.
Can I open the other one? Other one. One more video. It's a short video. I'll just...
None of the producers have any financial interest in the products or procedures shown.
See, in this kind of cases where the cornea is affected and things like that, where the anterior segment deficit, how thin it is, and or in a case of a penetrating keratoplasty, failed graft with cataracts, and the corneal vascularization is there. So it's going to be very difficult to do the surgery in this. In this also, we'd like to utilize the endo-illuminator thing. So even after scraping the epithelium, slight visualization is better. Then here, remember, whenever you're thinking of a bad cornea, always remember to plan. There can be, if it is a other side opacity, you can rotate the nucleus and bring where the visualization is there. Or you can go do a viscoat method, where I put a small little bit visco and carboxymethyl and then coat it with the viscoat. Even the viscoat don't give me anything, but still I say I'd prefer to use that. It's like a sandwich technique, and don't overfill always. Remember, when you are not visualizing, without realizing, we try to overfill the anterior chamber. That also can be done. Here, with the help of an endo-illuminator, we are able to see where the cataract is. Always switch off the microscope. That is very essential. Or make it very dim. And then you can use an endo-illuminator and see the visualization is much better. And protecting the cornea is also important. And in this case, in case you feel so, reduce the phaco energy and increase the flow rate and the vacuum in case you're finishing the surgery fast, or reduce the flow rate also, go with the slow surgery also. So here the cortical aspiration is also done, and the visualization is very poor in all these situations. And remember, always never overfill in case of a bad cornea cases. minimal visco using in the anterior chamber is very essential, because when we always will be tense when we are not visualizing, we'll always tend to overfill the thing. That will also make the cornea more cloudy. It will be slightly like not very tight eye. In that way, it's much better to perform the surgery. The other things are same, like single pass 4-throw pupilloplasty, performing in the same case. And remember, use the instead of the normal thing, you can use always the BSS saline. That is also very essential. The BSS saline of the Alcon BSS saline is much better. In this, we also charge the patient separately and tell them that they require this Viscoat and BSS. We have to explain to them why they are charged extra, and we have to tell them that it's very essential to protect their endothelium. Same case, we have done the single pass 4-throw pupilloplasty also in this patient. Same other things, like we finished it with the PDAC graft, because as you see the cornea is bad. I would like to thank especially Dr. Naveen for giving me this opportunity in AIOS. My only talk in AIOS. Thanks a lot. And I would like to thank Dr. Aisha and the other doctor, the two audience. At least we are happy. Otherwise, we are telling that we both will be staring each other. Thanks a lot, and thanks a lot for the audio visual and other team members also. Thank you. Yes, sir, we use that for normal cases also. And we switch it off. Otherwise, what happens is you will have too much glare. We always switch it off. And even in case where you don't find the rhexis is not great, like black cataract, we are using it for endoilluminator for this fighting the rhexis. Even after staining trypan blue, sometimes you may not say where the edge is, because the edge goes off in these cases. We use endoilluminator, it works well. Even the newer adapter microscope which has come, I don't know the name, like for 2.5 lakhs it comes. They attach with the microscope. Those also works better. Yeah. And the endoilluminator gives a much better than that. What I have seen is in those also the visualization is much better. This gives a much better thing. If no questions.